Our next speaker is Dr. Ingebretson, a role of ECMO in LV conditioning after lung transplantation.
So correction, I'm a nurse practitioner, but thank you. Good morning, my name is Emily Ingebretson. I'm a nurse practitioner with the lung transplant team at the University of California. I'm going to be in San Diego. I'm going to be presenting a case that highlights the role of ECMO in LV conditioning after transplantation of a PH patient with RV failure. There we go. So we'll start with a 46-year-old female who came to the emergency room with worsening shortness of breath, productive cough, abdominal pain, with a medical history of idiopathic pulmonary artery hypertension that was diagnosed back in 2019, as well as diabetes and hypothyroidism. She was compliant with her dual therapy PAH meds as well as her heart failure GDMT, which was pretty well optimized. In the emergency room, she developed acute hypoxia, perioral cyanosis, as well as cool extremities. Her ABG showed a compensated metabolic acidosis with a PaO2 of 166 and a lactic acid of 6.6, elevated BNP, and an elevated troponin T that was stable after a couple of lab draws. So her initial TTE, as you can see, showed a pretty distended right ventricle that was compressing the left ventricle, a nice kind of D sign on the peristernal short axis with during both diastole and systole. The read reported a severe tricuspid regurgitation as well as moderate pulmonic regurgitation, and her left ventricle end diastolic diameter was 2.7 at this point, and she had a moderate pericardial effusion. So she was started on low-dose dopamine and then titrated back off of that, had her first right heart cath, and that showed us that she had severe pulmonary artery hypertension with a wedge or a mean PA pressure of 59, a RA pressure of 19, and a cardiac index, fit cardiac index of 2.17 with PA sat of 55. After titrating up, she was started at that point on IV treprostinil and then titrated up on her dopamine. So she was finally titrated up to 21 on the IV treprostinil as well as 2 of dopamine. Got a second right heart cath, which showed refractory disease with a PA mean of 63, an RA pressure of 21, and a PA sat of 55 with a FIC index of 2.39. So at that point, we were consulted, the lung transplant team was consulted for evaluation, and she coded 5 days later, requiring via ECMO cannulation, intubation, and then high-dose pressors. So this is her post-code and cannulation TTE showing a offloaded right ventricle, allowing the left ventricle to fill a little more, so your left ventricular end diastolic diameter on this was 3.4. She also had some reduced LV function at this point. So about a month after the code, she ended up getting her bilateral lung transplant also with a tricuspid valve repair. She came out of the OR on ECMO, and postoperatively she required massive transfusion for hemorrhagic shock, which led to some elevated LV filling pressures despite diuresis. PA diastolic up to 30, which we were using instead of the wedge to preserve the PA anastomoses. So she ended up developing PGD grade 3, which slowly resolved with aggressive diuresis and intermittent afterload reduction. And 2 days following her transplant, she was decannulated from VA and put on VV ECMO. So this is her post decannulation from VA ECMO, so she was on VV at this point. The read reported a hypertrophic left ventricle and right ventricle, hypertrophic right ventricle with a hyperdynamic left ventricle. And then the diastolic function was indeterminate. So one of the concepts I wanted to discuss from this case is the idea of left ventricular conditioning or diastolic dysfunction following pulmonary artery hypertension and resolution of that pulmonary artery hypertension. So idiopathic PAH patient, lung transplant patient recipients actually have one of the highest one-year mortalities, up to 25% postoperatively. But one of the second best long-term survivals compared to recipients with other pulmonary diseases. So this is thought to be related to the PGD that's caused by this kind of small and unconditioned left ventricle that's prone to developing diastolic dysfunction when exposed to normal or relatively high filling pressures. So an idea as a solution to this is ECMO bridging perioperatively to allow the left ventricle time to condition to this new filling pressure. In 2002, a team in Austria looked prospectively at 17 lung transplant patients with PH and found that perioperative VA ECMO instead of cardiopulmonary bypass intraoperatively reduces the post-op or perfusion injury by reducing the flow through the lungs initially. Their study resulted in more controlled reperfusion, less aggressive ventilation strategies, as well as improved post-operative hemodynamics, but really no change in long-term survival. Another prospective study of 23 bilateral lung transplant patients for severe PH of differing groups in Germany looked actually at VA ECMO bridging for left ventricular conditioning while monitoring left atrial pressure, left ventricular end diastolic diameter, and invasive hemodynamics for weaning of ECMO. And they reported actually decreased total number of ventilator days, ICU days, and in-hospital days, as well as an increased 90-day and 1-year survival, which they reported up to 94%. Primary PH is only about 2 to 5% of our center's transplants and 5 to 6% nationally. And at our center, we only cannulate for ECMO once a year on those patients. And that data is not available nationally. So it may be a little bit difficult with these small sample sizes to determine whether ECMO is an appropriate support postoperatively for these patients. A potential larger surrogate population for this concept is the CTEPH population, and our PH group does about 180 pulmonary thromboendarterectomies a year, and they rarely use ECMO post-op for LV conditioning. Instead, they have success with simple inotropes. So in this particular case, VA ECMO is needed post-op because of the prolonged pre-op use and the patient's coagulopathy, leading us to believe she was going to need some extra support post-op to maintain her. We actually had a PH patient immediately after her who got a lung transplant who didn't require VA ECMO at any time perioperatively. So VA ECMO for support for LV conditioning may only be needed on a case-by-case basis, particularly since it comes with its own set of risks. But this area definitely would benefit from further research. That concludes my presentation.
Eddie, I know you're drooling over those echoes. Tell us what you see.
We were just talking, Bindu and I, so it's interesting. So just, I was just thinking about the hemodynamics with respect to the before the patient got really hemodynamically embarrassed, was interesting because the LV looked like it was going to be a competent LV and may not require anything, but it's interesting how you got to be sensitized to the fact that, that was enough to go ahead and throw off that whole interventricular interaction. Mm-hmm. And, but I was just struck by the fact that the wedge pressure was 9, and just to be clear on the reverse Bernheim, so it's not mistaken, it's severe TR, and a lot of times it's an acute on chronic process. These chronic PH patients can have a wedge pressure of 1 with a pancaked LV.
Correct.
So I want to make sure it's not a misguided statement what we talked about.
But it had massive transfusion. I mean, she kept saying that this was a sort of a stress test, if you will, for a large volume, preload increase suddenly for the LV, now accentuated with the extra fluids and blood transfusion.
And I will say the reperfusion injury, I mean, you could have, I guess the question was, you supported VA because of the way the LV was looking, obviously. I mean, do you have a lot of reperfusion injury that you support coming off or within a day with VV? I'm just curious if you can talk about that, given your experience as a lung transplant physician.
I have been with the program for only a few months now, so historically I don't have as much data, but so far we haven't had actually any patients require VV ECMO postoperatively, except for her, and that was just from transitioning off because she had severe grade 3 PGD.
Was heart-lung considered in this situation? And the reason I ask is we have this debate in our program. I mean, we do about 4 to 5 heart-lungs a year. if an RA pressure is greater than 20 and index is less than 2 and we cannot modulate it, we're ending up doing heart-lung. And I don't know if that's the right answer, because I think the Europeans do a planned VA ECMO before induction, and then they seem to get by. So it's kind of a controversial area. I don't know
have
if
to say
the panel.
a couple comments on that, because Dr. Schwitzberg and I were at dinner last night, and the person who taught me the most about this was Chuck Hoops. And Chuck really went into the literature on heart-lung. He was trained at Duke, and Dwayne Davis, also Dr. Davis, gave a lot of insight on this. In the old days of early lung transplantation and then heart-lung, you're absolutely right. There was a lot of reliance on heart-lung transplant for those really end-stage PH patients. But just like she demonstrated, I don't know how much transitions with ECMO had been had. The RV, this RV another week later looks like a normal person's RV. So I really think it'd be great to avoid heart-lung transplant. It's not my field, but what I learned from Chuck while I was doing it at UCSF with him was these patients can really double lung transplant and really rarely heart-lung. We did heart-lung on congenitals. We did one heart-lung transplant on an idiopathic PH patient that he actually centrally cannulated and saved their life because we didn't see recovery. And so he said, you know what, I'm in California, I'm gonna do a heart-lung block. And he did, and he took care of her that way. But I would say it should be the exception, but that's my opinion.
Yeah, I think it's the peri-operative time where people crash if you don't plan, right?
Sure.
If someone's very sensitive. I agree with you. I think that needs to be tweaked.
Two comments. One is, showed the data on the patient being on Remodulin at 21 and DOPA. I would argue that 20 is still not good enough. We should not be talking lung transplant in PAH patients in 2022, and unfortunately we still are. And the problem is still diagnosis and time and mismanagement. I think this lady, when we have patients in our center with Remodulin at 100, we know at some point they may need a double lung, but the best lungs to have are the native lungs. That's number one. And number two, we're proud of you. She's trained from advanced heart failure here and there. And actually, another comment is your center showed us ischemic reperfusion injury more than anyone else in the country with the PTE experience. So I think this is a fine case, but this can be used across the nation too. Because at UCSD, the time to bring these patients back to the OR, from the OR to the ICU is over 8 to 12 hours. I mean, you can get better for managing ischemic reperfusion injury than that. So, thank you.
Quick comment from the floor.
Yes. Thank you, Emily. My name is Rahat Hussain. I'm the lung transplant attending over here. Great case, by the way. Two comments and one question. You basically alluded to a very great question that the panelists are discussing, that in this era of triple therapy with pulmonary hypertension, the heart-lung transplantation is now a thing of the past. Number one, you very nicely alluded that in a patient who had a D sign, RVs completely distended and so on and so forth. With pericardial effusion, all the signs telling of significant person who will have a significant high mortality, these patients with a double lung transplantation only actually can do better, and the outcomes have significantly gotten better in this new contemporary era of the triple therapies, number one. Secondly, to Dr. Akanti's point that in this, you had your patient on 20 nanograms of IV therapy. In this day and age, we have patients who we transplanted 80 nanograms, maybe more, and they have a completely normal, lifestyle, and they do very well, actually. The third thing is that what I wanted to ask is that you said that your patient was put on VA ECMO, and then you transplanted the patient 1 month after. Was she still on VA ECMO during that period of time? And if so, that was a really accomplishing feat for someone to be on 1 month of VA ECMO and then get transplanted. So platelet dysfunction with Remodulin therapies and bleeding complications and walking, and how did you guys manage all those?
So she was cannulated for a full month before transplant because she didn't get any offers. She actually got an offer the day before we were going to delist her. We were progressing her with physical therapy, though we had a few times we tried to extubate her, then failed, and she also had like massive GI bleeding that I think may have been from the IV prostacyclin therapy. that wasn't resolving, that was requiring a lot of volume repletion or blood repletion and then hypotension. So her physical therapy development in that month was also not ideal. But I think, with transplant programs, you stretch a little bit to try to
Kudos
progress.
to your program, definitely.
Yeah.
This
Thank
was a
you so
great
much.
case.
Well done.
Thank you.